Hello and welcome to the Queen Elizabeth Patient Podcast. We're at the Proto Building and we've got two guest speakers today. We've got Michelle Derbyshire, one of our breast care nurses from Queen Elizabeth. Michelle qualified many moons ago, she'll not mind us saying, in 1987, and she has been a breast care nurse for over 20 years, so she's got many years of experience. And we've also got Rachael Lockerby here today as well. Rachael qualified in 2011. She worked on the elective surgical ward, looking after many patients experiencing breast cancer and surgery. She then became part of our team as a breast care nurse in February 2018, but she's just recently come back after having a little bambino. So she's a little bit nervous today. She's worried that she's maybe got a little bit baby brain, but she's got lots of experience. So what we're going to talk about today is reconstruction. And basically just try and break it down into different elements of what may be best suited for different patients. So who wants to kick off? What is breast reconstruction?
Well, breast reconstruction is surgery that our patients would have to create a new breast shape using surgical techniques, either immediate or delayed. They can use their own tissue, or we can use implants to create the breast shape. And also it often requires several surgeries to achieve the best possible result for you when you're having your surgery done. So it's a big intake, and
I think that's one of the things that we'll have to stress when anybody's dealing with the decision process of should they go along the line of discussing breast reconstruction. I think we'll have to make it clear that it's never just one operation. Would you agree?
Absolutely. And I think the most important thing is to explore all the options and realise that there's always going to be limitations to the surgery itself. And certain patients are at risk of higher complication rate than other patients. For example, if you've got a high BMI or if you smoke, then you're at increased complication risk.
So I think one of the things you can advise patients, especially if it's a delayed reconstruction, which we'll go back to about the difference between immediate and delayed, is that if you are a delayed reconstruction, would you advise patients to maybe, as soon as you come to that decision, is to look at stopping smoking?
Yes, definitely. It's all about health and well-being and about being in the best optimum position for yourself to be able to get through this surgery and, have a steady weight, a good diet, stop smoking.
Because that's one of the things as well is that, it's the recovery from reconstruction. We want you to get on with it as quickly as possible. And we know if you put the work in beforehand, generally you'd think that the recovery is generally a lot more straightforward, would you find?
It should be smoother that way.
Yeah, definitely.
So what reconstruction surgery options would we have at Queen Elizabeth if a patient was coming for a consultation?
So we've got a couple of options at the QE. We do implant-based reconstruction and a latissimus dorsi, and you can have that done with or without an implant. And we also do volume replacement surgery for patients who are going to have a bit of a deficit in the size of their breast following a wide local excision.
So if we think about probably one of the most simplest is the skin sparing mastectomy with an implant. So can you just explain a little bit about that?
Yes, of course. If you do a mastectomy but you leave the skin, so you're using your own skin as part of the envelope, and you would take out the breast tissue in the form of a mastectomy but use the skin, and in that area you'd put an implant in to give you volume. And
so is that one of the options that, if a patient wanted an immediate reconstruction, we could go along that pathway?
Could indeed. In certain cases, it's best to use an expander, which is a silicone shell that you fill up with saline to achieve a size that you're comfortable with, or you can put a definitive silicone implant in straight away. The surgeon will discuss with you what he thinks is or she thinks is going to be the best option for yourself. We've also got to think about the other treatments that you're going to be having after the reconstruction, and if you would be needing radiotherapy. So sometimes having the expander in, allowing you to go for the radiotherapy after your surgery, and then the expander would be replaced with a silicone implant.
And I suppose that comes back to what we were trying to say at the beginning is that it's never just one operation. So with an expander, already you're signing up for
at least
two surgical episodes. And then obviously, when you're reconstructing one breast, to get that sort of symmetry, to try and make the breast look as equal as possible, you're then sort of ticking the box for another lot of surgery for the other side.
Yes, absolutely. So you've got to go in with your eyes wide open and realise that you're not going to wake up on day one feeling as if you've got a new breast. It is a process, and there can be several operations: an expander, then an implant. You might need a nipple reconstruction if your nipple has been removed, contralateral surgery on the other side to match it up. Sometimes it's a case of increasing the size of the other breast if you're very small chested, so you could put an implant in the other side. Or if you're very large breasted, then sometimes the implant reconstruction doesn't achieve the same size as your natural side, so you would need a reduction on that side to get symmetry for you.
It is quite a lot of work, and if somebody signed up for having the skin sparing mastectomy, say with an expander, generally for the recovery, how long would that take? I suppose each and every person's different.
General recovery is about 6 weeks for any operation. With an expander, it should be around about the 6 week mark.
So that's a discussion that a patient would have to have with their employees as well, because I imagine they would need some time off to have that. And I think sometimes that's the difficulty for a lot of ladies, is the timeline of recovery, especially for delayed, if they've maybe taken maybe 6 months off for treatment.
And then they're thinking about coming back and having reconstructive surgery, and that's more time off work that maybe they're not sure that they can do.
Yeah. And I think one of the things is that, once the episode's open, that when they start discussing reconstruction, there isn't a timeline. There's not an expiry date once they've seen the consultant that they have to have that reconstruction done in, is there?
They don't have to have it done in a certain time frame. Some ladies may come towards the end of their 5 years follow-up and then decide, actually, now's the time that I want to have my reconstruction done. As long as, if you're within your 5 years that you're with your breast care nurse and the surgeon that you were under for your cancer treatment, then obviously we can refer you back into your surgeon to come and discuss reconstructive options. If it was outside of your 5 years of follow-up, then the patient would have to then speak to the GP to be referred back into the hospital to discuss those options with, it may be a different surgeon or the surgeon who they've seen previously.
And we talk about other options as well, and one of them is something that we called an LD reconstruction, where you can have an implant, an expander, Libel Filling, or you can have it done with all three. Do you want to just tell us a little bit more about that?
Yeah, so the LD reconstruction uses the muscle from your back. The surgeon will bring that tissue forward to use that to reconstruct the breast shape. Sometimes they'll use just that muscle and tissue, or they may use an implant as well to achieve the size that they need to try and symmetrise with the other breast. Sometimes as well, though, you need to have, like we say, further surgery. You're signing up for more than one operation here. It's not necessarily going to be perfect in the very first instance. So some ladies will need to have some Libel Filling, where we remove some fat from elsewhere, usually from the stomach, and insert that in, fill in any deficit and give a bit of volume to the new breast reconstruction.
I mean, all of these new techniques are things like with the Libel Filling. I'm sure, Michelle, in your early days, reconstruction was completely different to what we're seeing now. It's worlds apart.
Worlds apart from when I first started. Patients were very rarely offered immediate reconstruction. You would have your mastectomy, you would have your treatment for your cancer, and then you'd be referred to a plastic surgeon who would then do the reconstruction. It was very rare that you had an immediate reconstruction offered to you. And as time's gone by, the advances in surgery have just been absolutely phenomenal. So the ladies today have so many options available to them.
I mean, once upon a time as well, if you had quite a, multifocal, which means that there's lots of small elements of breast cancer within the breast, or if you had quite a large tumour in a breast, it was sometimes just automatic mastectomy, whereas now we can kind of manipulate the size of the breast.
You can indeed. You're quite right. If the tumour was a certain size, then it was automatic recommendation from the surgical team, you need a mastectomy. But with the advances in surgical technique, we can do what's called volume replacement surgery. So we can still safely remove the cancer area and a healthy rim of tissue. But in doing that, you backfill the cavity with some of your excess tissue that you may have underneath your arm or on your abdomen, and that fills the area to give you a good cosmetic outcome, but it also achieves excellent surgery so that the cancer is successfully removed without having to lose the breast. Again, because of this type of surgery, the breast is often on that side a little bit smaller, so you may need further surgery on the other side at a later date.
But I suppose it's a really good option for ladies that maybe want to steer away from using an implant. I think with all of the options, there has to be a little bit of compromise. Like when we talk about the LD reconstruction, there's maybe some ladies who aren't keen about having that scarring across the back, although they'll try and keep it in the bra line and hidden as possible. There's some ladies that just can't get their head around it being an additional scar and an additional sort of assault to the body.
Yeah, definitely.
And I think as well, they've got to be wary, I suppose, if you are a big gym bunny lifting a lot of weight, you may get an element of...
Not going to be the reconstructive option for you because that muscle's moved now and it'll impact whatever daily activities that you do. If you're in the gym every day, you're not going to be able to do the things that you were doing.
I think that's one of the big things is that before you come to see the consultant about all of these different options is to do your homework first. I mean, your best resource is always going to be a breast care nurse to talk it through, but I know things like Breast Cancer Care have got a really good website with all the different options available. I know that FACT, Fighting All Cancers, the local charity, does a lot of reconstructive workshops and information evenings.
And I think Maggie's do as well. They've got good resources in terms of getting you in touch with other patients who've had various reconstructions done. It allows you to explore people's experiences, really.
And there's just, like I say, it goes back to there's no pressure to make up your mind of what you have, because there's no right or wrong about which one. It just has to suit you. But again, we must make it clear that to do a lot of these surgeries, you must be in the best form of health that you can be possibly, and definitely smoking and getting your BMI down. Weight reduction is probably the best advice that we could probably give to you, and that would probably be the first step towards that. So what you might find when you're going through these resources is that you might see names for other types of reconstruction.
Yeah, so just because you've done your own research, you might have found, like you say, other types of reconstruction. They may not be on offer at the QE, but you can discuss them with your breast surgeon who, if they feel that you meet the criteria to have that type of breast reconstruction, we can refer you off to other hospitals to discuss that with their team. So it's not a blank no.
No, it's a discussion, isn't it, really? And one of the other discussions that we'll have is that, you know, there's some ladies who automatically think that if they chose to have a mastectomy, they can automatically get an immediate reconstruction, but that's not always the case.
No, it isn't. In certain situations, the team would advise and recommend a delayed reconstruction. In certain cases with a high-risk cancer, we don't want any post-op complications. We want the patient to get on with any other treatments that they may need, whether that be chemotherapy or radiotherapy. So that's the priority. So a simple mastectomy, then you follow up backup treatments, and then come back to having a reconstruction at a later date.
Because I think a simple mastectomy, the complication risk compared to when you're dealing with an implant is worlds apart, isn't it?
It is indeed. So it's a smooth running to get through your cancer treatments and then come back to think about the cosmetic effect. In that period of time, the lady will be able to use an external prosthesis that she can put inside of her bra to give her some shape. So in that case, only people that she chooses to tell she has had a mastectomy need to know, because the prosthesis would be hidden in her bra and she would be given one to match the other side as close as possible.
To the outside eye, you wouldn't know that she'd had a mastectomy.
And I often think some ladies that do wear the prosthesis often look, sometimes they've taken a lot of time to consider the bra that they're wearing, often a better fitting bra. And I think as well, when they've gone through the turbulence of all of these treatments, that sometimes it can be an easier option with the prosthesis, and maybe gives them an option further down the line where actually reconstruction isn't for them, because it shouldn't be a given that just because
you should have to have it done.
And that shouldn't be it. We've got a really good support group as well called Flat Friends. There's some ladies unfortunately do have to have both breasts removed for a lot of different reasons, and you know, we want to ensure that patients understand that they have the right, you know, that if they want both breasts removed, they don't automatically need to have a reconstruction. It's all down to
personal choice.
Yeah, totally. So, overall, what are the benefits, would you say, to having reconstruction or in general?
Well, in general, it's psychological, isn't it? It's all about you feeling good about yourself. It's about your body image, your self-esteem. Your identity as a woman is your shape, and it just makes you feel more feminine if you've got a reconstructed breast. But that's not taken away if you have had to have a mastectomy for whatever reason, patient choice or other. The prosthesis would give you that shape back. But we know that from a psychological recovery point of view, having a reconstruction
it just makes it feel a little bit more, as some ladies will describe it, feels a bit more normal than waking up sometimes from a surgical operation and maybe nothing being there, which is sometimes quite
can be quite traumatic for them, definitely.
And again, on the other side of it, there's some ladies who have had chemotherapy first, and when the breast's removed, it's almost like a relief that breasts in their eyes sometimes feels like a bad breast.
Yes, because it's a diseased breast. So, patients will say to me, I'm really looking forward to my surgery because I know that the disease is going to go. My cancer is going to be gone once I've had my surgery. So,
every single person is different. They're in different situations, different relationships, I suppose, different times of their lives, and we'll do our best to support whichever boat that's in. So for delayed reconstruction, what would you kind of say are the benefits of that?
The benefits can be that you've completed your cancer treatment, you've had time to consider your options and know what's right for you. Some patients that will have been using a prosthesis may find that they've struggled a little bit with bra choice and clothing choice, not being able to wear the V-neck, the outfit that they wanted to, that they felt a little bit lopsided. So they feel it's the right time to have a reconstruction because they've got more options, but it's completely and utterly an individual choice.
What are sometimes the reasons behind some ladies, feeling that they need to have a reconstruction? Do you think sometimes it's maybe from the partner, or sometimes we have the opposite way around, where some partners, don't want them to go through another operation, they're quite happy, they don't want to put any pressure on them, that happens as well.
It goes both ways, yeah. Sometimes the partner can be saying, you've been through enough, I love you just the way you are. But the lady herself, not necessarily putting pressure on herself, but just feels as if it's right for her. So, in that time, maybe at 2 years, it may be at 6 years. It's completely and utterly down to the individual.
And I just want to stress as well is that if people have maybe had a delayed reconstruction and they are waiting for surgery to be done, or they're finding it difficult to deal with something like a mastectomy scar and the change in body image, that we have got lots of counselling services out there to help with that as well, and to talk to your breast care nurse about what the services are involved to help them make the transition from losing a breast.
Yeah, it's really important that they know that we are at the end of a phone. So if they are struggling and they haven't explored those options of counselling before, to just let us know that they're
struggling.
They're struggling, yeah.
And it's okay to put your hand up and say that's the case. So again, sometimes some ladies may feel a bit guilty that, we've treated them, they've got rid of this cancer. So
it's still an ongoing issue that they're having to deal with every day, that maybe, like you say, the guilt, they don't want to say, I'm struggling with this because I've survived the cancer, I've had my treatment and everything's fine now, and it's however many years down the line.
And I suppose that's the psychological side effect of it all. But there is some risks and complications around breast reconstruction which are very, very physical, and we've seen a lot of this in our time. So whenever we deal with an implant, I suppose it's a foreign body. Can you tell us a little bit about your experiences of some of the ladies that have had complications?
It can be very traumatic for the lady. She's had the implant or the expander put in, but unfortunately she may get an infection, and initially an infection can be treated quite successfully with antibiotics, but sometimes it does need for the implant to be actually removed, and if that's the case, the cavity can be washed out and another implant put in, but sometimes it means going back to flat chested to allow the skin to settle down, especially if the skin has lost some of its blood supply and become a little bit necrotic. Then it's a case of going back to mastectomy and allowing it a few weeks to rest and settle before another procedure is thought about. But there are other things that we can do.
You know, sometimes I've seen where a lady's rang up to say that the breast looks like it's doubling in size, and seromas is a big complication when we're dealing with implants. You know, if there's a woman at home who's recovering from breast reconstruction and she starts to say that would happen, what would your advice be for them?
Well, they need to ring us so that we can review that. It's something that can happen after the surgery, and we do tell them that when they're being counselled for the operation, but they need to come in and be seen so that we can assess the level of seroma that's developed around the implant.
We use things like drains though to help.
Yeah, we do use drains. So some ladies are sent home with a drain in place after their operation, which may be in for, you know, a week or two after the operation, and that drains that fluid that the body produces. But when they come out, that can still build up, and they need to give us a ring so we can assess that. You may need to scan the lady to see if we need to drain any with a needle to relieve the pressure.
Because a lot of these implant-based reconstructions, we use material like the from pigs and cows. We use the lining of the I can't remember which part of the pig or the cow that they use. Don't quote us on that one. I'm sure your consultant will tell you a little bit more about that. But some of these slings, as they're kind of called, within the breast to support the breast during reconstruction, they do sometimes amplify the amount of fluid in the breast. So just to prepare ladies, I suppose, that these drains can stay in for like a week to 2 weeks. You know, during that time, we're expected to maybe sit up in bed. It's not the most comfortable of times of your life. You know, again, it's about preparation. You know, it might be easier for you to be in a single bed on your own when you're going through this recovery. And again, that comes back to why we, I suppose, hammer it down, why, you know, healthy living beforehand, to make sure that your body's up to all of these demands following your surgery, to make sure the recovery's as smooth as possible.
Those slings as well that we use, they can cause a reaction on the skin. It can cause a redness to the reconstructed breast. So often you need to, if that happens, you need to ring the breast care nurse as well, because like Michelle said, you can get an infection. So we need to assess whether we think that any redness to your breast reconstruction is from an infection, or could it just be that natural reaction that the body has when that piece of tissue is integrating with your own.
So if in doubt, give us a share. And just to kind of, you know, when we talk about these slings that are internal within the surrounding the implant, you might hear the words Veritas, Stratus
or Braxon.
These are tends to be the most popular, and it's down to sometimes just consultants' preference.
So you've got to be aware of religious beliefs as well, because obviously if it's an animal product, certain religions and certain, if you're a vegetarian, it might be something that it's not for you. So it's all about knowing as much as possible about the procedure, so that when you're signing the consent form, it's informed choice that you're taking.
And again, it comes back to when they discuss the consent as well. You know that there's some links that we've discussed with things. There's a very small link to things called lymphoma.
Yeah, it's abbreviated as ALCL, which is anaplastic large cell lymphoma, and there has been research to show that there's a link between implants and this type of lymphoma. It is extremely rare, and I stress the word extremely. Your consultant and breast care nurse would give you up-to-date facts and figures on how rare it is, but it's usually if you develop a fluid collection around the implant a few years on. It's not something that's immediate, but you've got to take it into context that there's thousands and millions of women have implants in every day, and you know, these patients have never had any problems at all. So it is something that you must bear in mind, but it's one of the very rare side effects, but we're obliged, as always, to tell you about these things.
And also as well is that, you know, signing up for things like radiotherapy and the effect that can have on the implant as well. Can you tell us a little bit more about that?
The radiotherapy can cause shrinkage of the implant. We call it capsule contracture, and that may mean that the implant needs to be replaced at a certain point.
Which is why it's a good idea then to use an expander rather than a permanent implant, because we know that the effects of the radiotherapy can impact your implant. So that might be why your consultant would recommend an expander implant in the first instance, because you're already signing up to potentially have more surgery done, and then replace that with your permanent implant after you've finished your adjuvant treatments.
Because basically, I suppose radiotherapy just sucks the kind of, fluid, and it just makes that skin so much more rigid. That's possibly one of the
elasticity goes from the skin.
It is indeed. So when we talk about delayed reconstruction for a lady that's had a mastectomy who's gone on to have radiotherapy, when we think of how tight that skin is, that option of just putting an implant straight under.
Sometimes it's not advisable. Sometimes you've got to have the surgeon to assess the skin integrity, see how elastic it is. Will it stretch up? Does it need some fat grafting first to soften the area, to allow the skin to soften and then stretch? Or would the surgeon just say, look, it's not an option, we'll need to go to the LD, the latissimus dorsi type of reconstruction in your particular case? So I think you've got to be led by your consultant to a degree, but also be part and parcel of the conversation and make sure it's the right choice for you.
So there's obviously a lot there to consider when you are going through reconstruction, and I think from today's discussion, I think we can safely say, you need to do your homework. There's plenty of resources out there to help with your decision. You've got your breast care nurse, you can contact them, and obviously your consultant is a fantastic resource as well to talk about the reconstruction. And it's never one of those decisions where they'll be left to make on their own. They'll be supported.
No, they'll always be supported and guided by the surgeon and by us about what we think is going to be the best option for them. But it's about patient choice as well. You've got all that information there for you, what options are out there, and have time to reflect on what we've suggested and give them time to make the right choice. Come back and have a discussion with us. We'll show them pictures of things of our previous patients, so they know what to expect, and then bring them back to see the consultant to discuss that again, make a final decision, and then plan the surgery and in what timescale do they want this done, and when can they be fit into a theatre list.
And, we have talked about a lot of negatives, I suppose, and the complications, but equally we do see a lot of successes. We've got a very, very talented team of plastic surgeons, and we've seen some great results as well, So, any question, please, contact us, do your homework. And I just want to say thank you so much to Michelle and Rachel for all of their experiences that they've taken from today. And thank you very much, girls.
Thank you.
Thank you.